So thank you very much for inviting us to this lovely conference. Today we want to share with you our experiences in conducting a new and innovative intensive trauma treatment program for adolescents. We did our research while working at ACADE. And ACADE is an institution for child and youth psychiatry in the north of the Netherlands, where both outpatient and inpatient treatment is offered for children and adolescents up to 23 years old, and their system. And while working at that time in the clinic of with the adolescents, we wanted to set up a new innovative trauma treatment. So we also decided to do research on its effectiveness.
Yes, well, let's start by introducing ourselves. Next to me is Ytje from Pelt. She's a mental health care specialist, general remedial educationalist, trainer, consultant, and cognitive behavioral therapist, EMDR Europe consultant, and trainer. She's working at Psy-zo, a specialized mental health care and education center in the north of the Netherlands. I am Petra Fokma. I'm also a general remedial educationalist, consultant, trainer, and cognitive behavioral therapist, EMDR consultant, and also researcher, and working as a practitioner, trainer, and researcher at Trivio Care, also an institution in the north of the Netherlands.
Hi, let's start our presentation. So today we want to tell more about the clinical intensive treatment program for adolescents suffering from severe PTSD, wherein we combine prolonged exposure, EMDR therapy, and physical activities. Now, we already introduced ourselves. Yes. Here you can see our email address. If you have any questions later on, and you can send us a mail so we can get in touch. Now here, we want to show you a little video about Ruinewold, the children of Ruinewold. Ruinewold is a little village that became world news in October 2019. A police team discovered a father with 5 adult children in a remote farmhouse. The children were not registered, did not attend school, and had been living in total isolation in a locked room of the farm for years, waiting to the end of times. It was son Israel, then 25, who had fled from the farm shortly before, and who, in a completely confused state, had asked for help in a local cafe. 3 children, Shin, Edino, and Marianne, had previously fled on their own. When the discovery of the family became world news 2 years ago, they together decided to make a documentary about their lives. And the Dutch watched it with bated breath, the broadcast, and in which the 4 oldest children tell about their past and their terrible memories of their father, Gerrit-Jan. The oldest 3 children led a double life, and we like to show you a short introduction of this documentary in which the anger, the fear, but also the compassion and the love are visible.
Ja, je was wel gewoon echt bang.
Zij was ook fysiek agressief.
Ja. Dan ging die zo lang wurgen tot je dan bijna het gevoel had dat je doodging en dan liet hij los.
I want to say, I want to say.
Het beste is gewoon maar er helemaal niet over te praten en maar net te doen op school alsof Israël er helemaal niet zijn. Ja?
Als jij dan de geest van je moeder belichaamde voor hem, behandelde hij jou dan ook anders?
Ja, dan zag hij mij gewoon echt als zijn vrouw. Als je met hem sliep en zo was het gewoon hetzelfde.
Seksuele handelingen?
Ja, dan ging hij zo lang wurgen tot je dan bijna het gevoel had dat je doodging en dan liet hij los.
Mijn moeder die zit gewoon op de stoel en die zit een soort van ook lachend bij. En dat gaf voor mij ook wel echt duidelijk weer van, nou ja, van je laat het toch met je kinderen gebeuren. Ieder kind mist op een gegeven moment gewoon zijn ouder. Ik denk, dat zit er ook gewoon heel erg. Weet je, je wil niet de vader in de gevangenis en je wil niet de moeder die overleden is. En weet je, dat wil je niet.
Well, this was a short introduction of this documentary, and we wanted to show you this because it shows the difficulty of these young people who are having a very difficult history, and all the PTSD things, PTSD
Symptoms.
Yeah, symptoms. Thank you. They've got. And that's what we want to tell you in this slide, because what is PTSD? What is trauma? Well, trauma is that you have been exposed to one or more traumatic events directly as a victim or a witness, or indirectly, having heard about them from a close person, for example. People with PTSD show a minimum number of symptoms of 4 clusters. The first cluster is intrusive symptoms. That means flashbacks or nightmares. Cluster 2 is a persistent avoidance of memories, thoughts, feelings, people or places that evoke memories of the traumatic event. Such as the farmhouse you saw in this movie, it evokes memories in these children about everything that's happened there. Also, there's a cluster number 3 that are negative changes in cognitions and mood, such as exaggerated negative beliefs about oneself, others, or the world, or reduced interest in activities. And the 4th cluster is an increased arousal and reactivity. The symptoms are present more than 3 months.
Okay. Now, if we look at the typical reactions in the developmental state of the adolescent, we can see shame of their own vulnerability and dependency. Yeah? It's a developmental stage in which the person wants to do things on his own, without the parents or without anyone following them. They want to do it by themselves.
Yes.
So, excuse me. So the vulnerability that trauma, typically in this developmental stage, is combined with is very contradictory to the normal needs of this developmental stage, in which you want not to be dependent of the other, right? You want to do it yourself. So we also see the fear of being found different or abnormal, that people can show it on your face, that you have this traumatic history. We see aggressive or destructive fantasies like want to kill the killer or want to kill the perpetrator. We see radical changes in negative core beliefs. We see the development of risky behavior, like drug abuse. We also see reenactment in behavior and the tendency to repeat, in which the victim, the patient, the adolescent, has a bigger risk of being a victim again, over and over again.
Well, we would like to present you with some statements about trauma treatment in adolescence, which can only be answered dichotomously. If the proposition is a fact, then raise your digital hand, not your normal hand, but your digital hand in Zoom. If it's a myth, you don't have to do anything.
Just sit and relax.
Sit and relax. We start with statement 1, and statement 1 is, it is irresponsible to start trauma treatment for adolescents without a stabilization phase in which the adolescent learns emotion regulation skills. So please answer fact or myth.
Fact, raise the digital hand.
Myth, do nothing, just
nothing.
sit still. Yes. Okay.
Okay.
Well, we can't see your reactions now because, well, the technique is very good, but not that good. We want to take you to some research and information we know about this statement. So
Yeah.
Ytje will tell you something more about
So,
it.
is it a fact or myth to stabilize or not? As you can see on the slide, there's already a substantial body of scientific evidence for the earliest possible deployment of trauma-focused treatment. In any case, the severity or complexity of these symptoms do not seem to be valid arguments for offering patients a course of stabilization or denying them treatment according to the multidisciplinary guideline for anxiety disorders.
Yes, it's really convincing. Then we've got statement 2. And also here, a small reminder, if the proposition is a fact, according to you, then raise your digital hand. And if it's a myth, you don't have to do anything and sit and relax. Statement 2, or position 2, trauma treatment for adolescents should be offered in a dose, meaning at a maximum frequency of 1 therapy session per week. Fact, raise your digital hand. Myth, do nothing.
So, and here we go again. And to dose or not, there is a lot of research into the intensive variants in adults. For example, Ehlers did research in 2014 in which the patients have been offered 1 week, 1 session per day, and it was as effective as 1 session a week for 3 months. So after 7 days of treatment in a row, 73% no longer had PTSD. And there was no higher dropout, and there was no symptom worsening. So this is a very promising first research to our knowledge into the dose. Huh?
Yes, and something I think it's good to say that it was were a great amount of patients. There were 121 patients were included in this research.
Yeah, yeah.
Well,
and let's go also to the research of Woudenberg in 2018.
Yes.
They offered a large group of people 2 sessions, 2 weeks, 2 sessions per day, in which 1 session was prolonged exposure in the morning and EMDR therapy in the afternoon. So 2 sessions of 90 minutes a day, 2 weeks. They see a significant reduction in symptom severity, and 82.9% significantly meaningful responded to this therapy, and 54.9% no longer was fulfilling the diagnostic criteria after 8 days of treatment. And there was an extremely low dropout rate, a dropout rate of 2.3%, in which normally there is a huge amount of people who drop out during the trauma-focused treatment.
Yes, so it's very promising, and these were the results of the research with adult patients. And now we want to tell you something about the research into the intensive variance with families. Mavison et al. Quite recent had a research and they had 2 sessions per day, 4 days in a week for 6 weeks. So it was a little bit longer, but also 2 sessions a day. And after 2 weeks, 90% of the children and parents no longer had met the criteria of PTSD. It was and research existing of 9 parents and 10 children. They were
So
included.
it's a small group,
Yes,
a
a
relative
small
small group.
And it was in a therapy program which was named King's ID, and it was for parents and children and consisted of 2 sessions of 60 to 75 minutes per day. Between sessions, family members were supported by the carer who encouraged them to be physically active. So it's a very promising outcome, because after this long period, there was no dropout, and there was a significant reduction in psychopathology. And the results also maintained after 6 months.
So very promising.
Yes.
Yeah. Now take a look into the intensive variance meeting the adolescents. Hendricks et al. Is the only one who did research in this age group. She offered their clients an intensive prolonged exposure therapy program, who consists of a group of 10 adolescents with severe PTSD and comorbid disorders after multiple interpersonal trauma. And in this program, there was no dropout. And 40% of the adolescents reached diagnostic remission of their PTSD from baseline to post-treatment, and 80% even from baseline to follow-up at 3 months and at 6 months. So very promising results.
Yeah, so in summary, intensifying trauma-focused treatment may lead to better treatment adherence, lower dropout rates. Possible because there are fewer interfering variables that may play a role, such as reduced time between therapy sessions to build up anticipatory anxiety. And that's also what we saw and heard from our clients. They said it's good to focus 1 week or 2 weeks really good on the PTSD treatment, and not all the time treatment and then go to school and other things.
Yeah, they really preferred multiple treatments in a week. Yes. Over a short period than weekly frequency,
1 week, 1 hour,
60
yes.
minutes, and then being in a treatment for sometimes years.
Yes,
yeah.
Yes.
So,
Well, then we've got a new position here for you. A small reminder, again, if the proposition is a fact, then raise your digital hand, and if it's a myth, you don't do anything. Well, the position 3 is, it is best to use different trauma-focused methods within the treatment, meaning to combine different trauma therapies. Fact or myth?
Now, let's take a look at the research of Van Minnen in 2020, who did an exploratory study in which the prolonged exposure and EMDR therapy were combined. And this research showed the successful combination of prolonged exposure as the first therapy in the day, and second, the EMDR therapy. So the sequence in which it is offered is really an important factor, because in a second study, she researched if you offer only EMDR in the morning and prolonged exposure in the afternoon, or the other way in which the prolonged exposure is offered in the morning, EMDR therapy is offered in the afternoon. The results are better when you offer the prolonged exposure in the morning and the EMDR therapy in the afternoon. And the clients preferred that sequence also. So there was a significantly higher reduction in PTSD symptoms if it was offered in that sequence.
Yes. And the patients also preferred this sequence of PE first and then EMDR because they thought, they think it's significantly more helpful in this condition.
Yeah, and the question is whether a combination of two first choice guideline treatments for PTSD, yeah, in which prolonged exposure in EMDR therapy leads to better treatment outcome regarding PTSD and comorbid symptoms than a non-combined trauma-focused treatment program. Because these therapies seem to be based on different working mechanisms, it is conceivable that prolonged exposure is better for some patients and EMDR is better for other patients. As far as we know, however, it is not yet known which trauma-focused treatment can best be used for which specific symptoms. By combining these two therapies, we expect an increased value of the therapy effect.
But further research is needed.
Yeah, further research is also now in the make.
Yes, yes.
So,
well, the adolescent's perspective on the combination of therapies. We asked the adolescents what their perspective is, and they said it's a really good combination. PE, prolonged exposure, made me see all the details. With EMDR, that became more and more difficult. Another one said the combination was good for me. Through PE therapy, I learned to talk about the shitty side. I couldn't do that at first. I think PE is a special therapy, stupidly talking with someone who's trained for it. Well, another one said PE opens it up and EMDR provides the relief. And that's what many of the clients said. It both works, both in a different way, and well, you can read the rest. It's they are very positive about this combination of therapies.
Okay, now let's go to the third proposition, or the fourth proposition already. In the context of CPTSD, trauma-focused therapy is best provided by only one therapist, so the adolescent regains confidence in adults. Is it a fact or a myth?
Yes. Well, there's also been research on this one. It's called the therapist rotation model. And the therapist rotation model is a novel approach for implementation of trauma-focused treatment in post-traumatic stress disorder. Results described in the article you see here suggest that therapist rotation is a new emerging approach, which is a reduction in therapist fear of applying trauma-focused treatment to PTSD clients. Increased willingness or readiness, awareness of trauma-focused treatment, and decreased avoidance behavior within trauma-focused treatment, which may lead to better implementation of trauma-focused treatment. We're talking about a therapist rotation model in which more therapists, something about 5 to 7 therapists,
or even more.
Yes, or even more in 2 weeks are therapists of one client. So one client has 5, 7 or more therapists in his whole trauma treatment program.
So maybe in the morning, Petra is offering the prolonged exposure. In the afternoon, it's me who gives the EMDR therapy. Maybe Rose is in the next morning for the prolonged exposure. And Jen is the one in the afternoon for giving the EMDR therapy, etc.
Yes, and Van Minnen discovered that the therapeutic relationship is assessed as good by the clients also due to insecure attachment styles. So the therapeutic relationship, they assessed it as good. Conclusion, it's a promising emerging approach to improve the implementation of trauma-informed treatment, in which also the therapists are having more confidence in providing the trauma therapy.
Now let's let's see to the adolescents' perspective on therapist rotation. We asked them talk about the therapist rotation. How do you think about it? How do you feel about it? And most of the clients were very, very moved by working with different therapists because some said, I have a new different idea now about social workers. They do listen to you. And another said, give me several therapists. It helps me because several therapists say the same things. For example, about guilt. And they all have different voices, which has a different effect on me. And that works well. And yeah, we really love this one. If you always have the same one, you would get into each other's face too much. It's really adolescent's perspective. And this was striking. Actually, it was working together, the feeling of a team around me. So
yes, and there was one client, she said,
I really hate it.
Yes, I didn't like it. Always someone else is really annoying. It's hard to do your story over and over again. And what's really nice is that
really striking.
Yeah, she didn't like it, but she had the biggest effect of the treatment of all the clients we included. So she might not like it, but it works for her and it's effective for her. And that's really important to know.
Yeah. So now, then
for the treatment of children and adolescents with clinically relevant levels of PTSD symptoms, the NICE and WHO International Treatment Guidelines recommend the application of trauma-focused cognitive behavioral therapy or EMDR therapy. And the same holds true for children and adolescents who suffer from the disabling effect of early childhood traumatization. We talk about childhood traumatization, you also saw on the video introduction of the documentary. The rationale for developing, implementing, and researching an intensive trauma-focused treatment for adolescents lies in the fact that there is a high dropout rate in this population. Adolescents drop out a lot in trauma-focused treatment. As a consequence, a significant number of patients ultimately do not receive treatment they could benefit from. As presented, there is evidence suggesting that retention in treatment decreases when treatment is intensified. That is, applying a higher frequency of therapy sessions within a shorter time frame, such as 10 sessions a week. The purpose of the present study, our study we did by ACARE, mental health clinic, was to determine whether this brief trauma-focused treatment program that was effective for adults could be also effective for adolescents with severe PTSD following interpersonal trauma measured by using the golden standard for classifying PTSD in children and adolescents, the CAPS-CA4. We predicted in this study that this treatment program for adolescents would be associated with a significant decrease in PTSD symptoms, as well as a decrease in the number of adolescents fulfilling the diagnostic criteria of PTSD. Furthermore, we predicted a low dropout rate. And we wanted to look at if the treatment program would also be safe for this population, which means an absence of adverse events such as suicidality or serious self-injurious behavior.
So let's take a look at the target group. The patient included in our study received trauma-focused treatment for the duration of 2 to 4 weeks. And in this period, 27 participants, in which the greatest were female and the mean age was 16 years, was referred by their general remedial practitioner, psychologist or psychiatric, from outpatient services to ACARE intensive care development department for trauma-related problems in the Netherlands. Of these patients, we consecutively included individuals fulfilling the following criteria: age between 12 and 18 years, meeting the diagnostic criteria of PTSD according to the Diagnostic and Statistical Manual of Mental Disorders, and had previously received trauma-focused treatment in an outpatient setting, which was stopped prematurely due to severe dysregulation, such as the suicidality, self-injurious risk behaviors, or a presumed high risk of decompensation. Or trauma-focused treatment had not started because the risk of such adverse events occurring was deemed too high based on the referring clinician. In short term, intensification is needed because the outpatient trauma treatment has stagnated or is not being dared. In whom previous trauma treatment was not used because of too much instability, in whom there is evidence of suicidality, self-harm, extreme gloominess.
Yes. Well, our treatment program had the following key elements. The program consisted of a combination of two manualized evidence-based treatment for PTSD. That is the prolonged exposure therapy and exposure in vivo in the morning, and EMDR therapy in the afternoon during 5 consecutive working days. Patients received 2 individual sessions per day for the duration of 60 minutes each, and twice a day a patient would participate in physical activities lasting also 60 minutes per session. Patients' information about their trauma history and PTSD symptoms was used to develop an individualized case conceptualization. Well, there we had all types of information that was needed for therapists to provide the therapy. One specific memory was processed per day, and the memory targeted with PE in the morning session was also again targeted in the afternoon using EMDR. The duration of the treatment was not determined in advance, but dependent on the progress made with the predetermined target memories. In other words, treatment was terminated when the client said, I have achieved my goals for this treatment.
Yeah, and each day a multidisciplinary meeting took place among the therapists in which information from the exposure session in the morning was transferred to the EMDR therapist who would conduct the afternoon session. So the therapist, exposure, the prolonged exposure, and the EMDR therapist rotated between the individual treatment sessions, which meant that one patient had approximately 5 to 7 different therapists. And the therapist provided psychoeducation about PTSD before and during the treatment program. And in addition to the daily treatment schedule, the patient spent the remaining hours of the day together with the rest on the patient group, for example, during meal times, or spending their leisure time together, or on their own, so they can work on school assignments. And patients were also able to receive visitors from their own network during their leisure time. So patients went home in the weekend, and further, the treatment program did not contain any form of stabilization in that prior to processing of the traumatic memories. No relaxation and no emotion regulation skills were trained.
Because we saw in the what we showed you in the research, that is not really effective for PTSD treatment. So we did not use a stabilization phase.
No.
Okay. Well, here you can see a video. On this video, you see the beautiful grounds of the clinic where the young people stayed during their treatment. And you can see some of the attributes we used during the exposure in vivo, such as alcohol, tobacco, but also fake penises. Let's take a walk around the grounds. You can see the woods and the hidden cottages. Well, the practitioner who specializes in boxing, coaching for young people, explains here the purpose of boxing. The first aim is to be able to unload, to get out of your head for a while and enjoy boxing. The second aim is to increase the heart rate in order to continue processing. The last goal is to experience strength in your own body, to experience what you can do with your body in order to feel better and stronger mentally. Besides boxing, we offer the young people guided running, mountain biking, fitness, or basketball. This is all offered in a group in order to not only activate them, but also let them interact with other young people. In the afternoon, we offer the youngsters an EMDR session followed again by activation. So we're walking around the grounds again, and we're going to the boxing. Here you see the active boxing on video. For us, boxing consists more of much more than ramming on a punching bag.
Yeah.
Well, afterwards, the youngsters go to their residential home to have their meals in the group, to take part in activities, but also to receive visitors. Family, friends are welcomed in the house where the young person has his own room to stay during the stay.
Now, the comorbid problems of the young people have been identified, and the problems that occurred most frequently, in addition to the PTSD, were mood disorders and developmental disabilities. Anxiety disorders and personality disorders also occurred. On average, the adolescent in this study had 2.2 disorders.
Yes, next to the PTSD diagnosis. Yeah. Yes. Well, here you can see the traumatic events that adolescents in our study had experienced. Domestic violence was the highest, but also maltreatment, sexual abuse were very high. Traumatic loss and grief and medical trauma were also there in their history.
Yeah, a little less on the frequency. And if you think again about the video you have seen of the children of the Rhine you can see also the domestic violence, the maltreatment, the sexual abuse, but also the traumatic loss and grief. And they lost their mother. And she also says about all the feelings, and nobody wants a father in a prison and a mother who dies.
Yeah, they lost their mother, but also their father,
yeah,
in a way. Yes.
Yeah. So let's take a look at the procedure. And the presence of a PTSD diagnosis and the level of severity of the PTSD symptoms were assessed using a clinician-rated interview by independent assessors. The assessment was carried out prior to treatment, at the end of the treatment, and at follow-up 3 months after treatment.
Well, we included in this study 27 patients. They had a mean age of 16.1 years. The majority, here you can see, the majority had a very high PTSD severity score measured by the CAPS-4. The total severity score, CAPS-4, is the left, you see on the well, how do we call it? On the graphic, on the table.
Yeah, the graphic.
Yes.
On the left side.
Yes, the mean score was 84.85. That's really high. All patients had been exposed to one or more interpersonal traumatic experiences and displayed a high level of comorbidity. None of the patients dropped out during treatment. Well, I think this shows a lot, because at post-test, 32.59% of the clients, or the score on the CAPSCA is, sorry.
Yeah, on the left, you can see the pre, and in the middle, you can see after 2 weeks, measured after 2 or 3 weeks. And then you can see that from 84.85, it crashed down like 42.59. So that's a very, very big effect of 2 or 3 weeks treatment.
Yes.
And even after follow-up, it continued. So we were very shocked, surprisingly shocked by the great results that our study showed, because we already have seen it with our own eyes as clinicians, but now also in the research, it is translated into
and it's similar
this
as
graph.
with the adults.
Yeah,
And
sure.
the majority of our patients showed a clinically meaningful response to treatment based upon the CAPSCA scores. And at the end of treatment, 63% of the patients no longer fulfilled the diagnostic criteria of PTSD. None of the patients showed PTSD symptoms worsening. So that's a very a good result.
And none dropped out.
No dropout. Yes.
So now, okay, so the results show a significant decrease in CAPSCA-4 scores from before to after treatment. 81.5% showed a clinically meaningful response. The average admission time is 13 days of treatment. 63% no longer met diagnostic criteria of PTSD after treatment. The dropout was 0. And the results maintained after 3 months of follow-up. And there were no adverse events during the treatment. With no patients.
No.
No.
Well, in summary, we can say that this form of trauma treatment is safe and effective for adolescents with very severe PTSD comorbidity after series of chronic traumatic events. And we mentioned it earlier, but no dropout. And that's very good for these adolescents because they're in a vulnerable state of time in the age. And that's really good news.
Yeah, so now we asked our clients to just point out one message to you, to the clinicians in this world. So here are their messages, it's written by them. They said, just do it. Some said, back to earth with an ITT, and ITT means intensive trauma treatments. Hand in hand, we extinguish the trauma fire. ITT, we go through SAT -3. ITT is something so effective you don't often see. ITT, now that's a good idea. ITT started right away. ITT, it's the only way, and this one is really, really, really nice. ITT for anyone with a complex case. Everyone, almost everyone, can benefit from a trauma-focused treatment, even when earlier outpatient treatment did not help you, did not give you that relief that you are searching for. There is hope.
And then you need a therapist who is not scared of intensifying the trauma treatment. Just do it. That's what they want you to know.
Yeah. Now, here you can see our article.
Yes, that was published in the European Journal of Psychotraumatology, and that was in 2021. Yes, really recent, yes. So if you want to have it, you could find it here, or you can send us an email and we get it to you.
Yeah, even if you have any questions,
yes,
or you want to discuss something, or no, just let us know. We were really glad to present at this conference, and we thank you very much for your attention.
Yeah, thank you, and maybe see you next time.
Bye.
Bye.